Glaucoma is one of chronic and severe diseases of the eye, and we can compare it with, for example, arterial hypertension, but inside the eye. Inside the eye. So, what about glaucoma? Glaucoma is a group of chronic eye diseases with different etiology, accompanied by a triad of signs. First of all, it is increase of intraocular pressure periodically or permanently. Then it is optic nerve atrophy and characteristic changes in the visual field. Let's speak one by one about these signs. Mhm. But firstly, we need to speak about glaucoma and about clinical signs of this group of disease. Glaucoma is a severe disease that more common in person over the age of 40, but in rare cases can occur in younger persons. It is one of the leading causes of blindness for people over the age of 60 all over the world. And many forms of glaucoma have no warning signs, and vision loss due to the glaucoma cannot be recovered. So, it is important to recognize this disease in early stages, not only for ophthalmologists, but for doctors of all specialty. Any doctor should know signs and symptoms of glaucoma. Uh, the intraocular pressure. What is it? Uh, Intraocular pressure or IOP is a fluid pressure inside the eye. It helps to drainage of the aqueous humor, provides metabolic processes between the aqueous humor and eye structures. It depends on rigidity, rigidity of the eye membranes, amount of all structures inside the eyeball, drainage of the aqueous humor. There are two main types of intraocular pressure. Firstly, it is true IOP or PM0. It is taken by tomography. The normal rate is from 9 to 22 millimeters Hg. And the second one is tonometric IOP. It is PT. The normal rate is from 16 to 26 millimeters Hg. What is aqueous humor? We spoke about it in the anatomical lecture, and we must only to repeat this information. It is produced by the ciliary body. It fills the posterior chamber and then it fills in the posterior chamber and then flows in the angle of the anterior chamber. Uh, it is processes of the ciliary body. The epithelium of these processes produces the aqueous humor. It is the posterior chamber. It is the uh, lens, crystalline lens. Here there is aqueous humor. Then it is goes through the pupil to the anterior chamber and go then to the angle of the anterior chamber. Chamber here. Then the aqueous humor flows through the trabecular network. It is here. Schlemm's canal and then through 25 or 30 collector canals into the episcleral veins. Here, episcleral veins. This variant of aqueous humor going named trabecular pathway. And there is another variant is uveoscleral pathway or unconventional pathway of outflow of aqueous humor. It is variant when the aqueous humor grows through the ciliary muscle and other downstream tissues. It is here. Uh, the aqueous humor is a transparent fluid. Its density is 10 1.005, and there are nearby 0.2, 0.5 millimeters in the human eye. Uh, it contains a complex mixture of electrolytes, organic solutes, growth factors, and other proteins that supply nutrients to the non-vascular tissues of the eye. That is trabecular network, lens, corneal endothelium. Um, and one of the main work of the aqueous humor is to maintain the intraocular pressure and inflates the globe of the eye. About the classification of glaucoma. Classification of glaucoma, there are different variants of it. First of all, by origin. There are two variants, primary glaucoma and secondary glaucoma. The second variant of classification, due to the mechanism of increasing the level of IOP. It is open-angle glaucoma and closed-angle glaucoma or angle closure glaucoma. Um, by clinical course, stabilized glaucoma and unstabilized glaucoma, and on morphological and functional conditions of the optic nerve, mild glaucoma, moderate, severe, and stage glaucoma. 1 second, please. I will come back in 1 minute. Okay, I'm here. And so there are there are four variants of glaucoma due to morphological and functional condition of optic nerve: mild, moderate, severe, and end-stage glaucoma. By the time of occurrence of the disease, there are four variants too. It's congenital, when the glaucoma come up to 3 years old. Infantile glaucoma or infant glaucoma from 3 to 10 years old, juvenile glaucoma from 11 to 35 years old, and glaucoma of adults older than 35 years old. By intraocular pressure level, normal IOP when tonometric IOP up to 25 millimeters, and moderately level IOP from 26 to 32 millimeters, and high IOP when the tonometric pressure is from 33 and above millimeters hydrogram. And first of all, we will speak about primary open-angle glaucoma or POG. Pathogenic mechanism is defect of the outflow of aqueous humor as a result of trabeculoplasty. Clinical features. It occurs over the age of 35 years. The angle of the front camera is open and more common in men, in 65%. The course of the disease is almost asymptomatic until the appearance of significant defects in the visual field, focusing to consult a doctor. Sometimes patients complain of a feeling of heaviness, swelling in the eye, a feeling of false tears, note the frequent change of spectacles, both for long distance and for the near. Primary angle glaucoma is asymptomatic. It is the main clinical sign. It is asymptomatic. Patients don't have any symptoms till the visual field losing comes to the center of the to the central part, and we will see it during the discussion. In the left side you see the normal eye and the normal variant of optic disc. And when the glaucoma comes and intraocular pressure become higher, it there, here I must remind you that here there is a lamina cribrosa. It's very thin part of the membranes of the eye, and here the ocular pressure uh, press the optic nerve, and it become deeper, and excavation of the optic nerve become deeper and wider. And due to this excavation, to this press, the optic nerve atrophy comes to this eye with glaucoma. There are three main series of POC origin. It is firstly vascular theory by Fedorov. Uh, it tells us that POC is a result from ischemia of the anterior segment of the eye. Metabolic theory by Bunin. When normal composition of the aqueous humor is changing, that leads to the outflow disorder. And the third variant of series is functional block of the Schlemm's canal. This theory was made by Nesterov, academic Nesterov. And it tells that trabecular meshwork separates anterior chamber and scleral sinus. Pressure in the eye is higher than in the sinus, therefore trabecula is always arcuate in Schlemm's canal, and trabecula gets soft with age, becomes displaced and blocking scleral sinus. So the IOP is increasing. Uh, some clinical features of POC. Intraocular pressure, tonometric variant is more than 26 millimeters hydrogram, and true intraocular pressure is more than 22 millimeters. Uh, of course, we speak about the pressure without treatment when we haven't started the treatment of the glaucoma. What about optic disc? It is failure of the bottom of the physiological cup and its extension. In the final of the disease, the excavation becomes total and deep. Atrophy captures not only the optic nerve but also the part of the choroid around the optic disc, forming a ring of peripapillary atrophy or halo of glaucoma or glaucomatosis halo. Uh, I show you here. Here on the picture, you see the atrophy of the optic disc with glaucoma, and normally we can see the vessels going from the central part of the optic disc, but here we see that the pathway of the vessels is near the border of the nasal border of the optic disc. And here the white round part of the optic disc, it is the excavation. We see the narrowing of borders of the field of vision begins with the nasal side, then from above, below, and from the temporal side to the tubular visual field. Here we have the visual field with starting of narrowing, then just going to the center more, and only the tube variant of visual field. Uh, and then after this variant of visual field becomes bleedness. Uh, there are four stages of primary open angle glaucoma, and each stage has its own clinical signs. Stage 1, mild glaucoma. Intraocular pressure may be raised not permanently for 24 hours. high IOP in the morning and low before getting in the bed. An IOP variation does not exceed 5 millimeters within 24 hours and 4 or 5 millimeters between right and left eye. The optic disc is pale pink. The excavation of the optic disc is dilated but doesn't reach the edge of the disc. The visual field changes narrowing start with nasal segment from 60 to 50 grades, blind pot excavation, and small paracentral scotomas occur. So it's nearby normal. Optic disc, vessels, excavation, and visual field. It's nearby normal. Only 10 grades of visual field goes up. The next stage, stage 2, moderate. Glaucomatous atrophy of the optic disc occurs, and the excavation of the optic disc is expanded. In some parts can reach the edge of the disc, so the excavation become deeper and wider, and in some parts can go to the edge of the optic disc. Significant changes of the visual field in paracentral part combines with its narrowing in superior and inferior nasal fields from 50 to 15 grades. Here you see the specific paracentral scotoma of glaucoma. Uh, Here you see the visual field scheme, and here the normal disc with normal visual field, and the changed visual field with changed optic disc. Here you see the deeper, deep variant of um, excavation and wide too. It's normal disc. The next stage is stage 3, severe glaucoma. IOP is raised permanently within 24 hours. Glaucomatous atrophy of the optic disc comes, and optic disc become pale. Subtotal excavation reaches the disc margins. Boundaries of the visual field are concentrically narrowed, and in one or more segments is less than 15 grades from the fixation point. The fourth stage or end stage of glaucoma or terminal glaucoma. IOP is raised permanently within 24 hours. Visual acuity is absent, or there is light perception. Mostly it is incorrect light perception. Sometimes there are small areas without pathology, can be temporal. And optic nerve atrophy, of course, optic disc is pale, excavation is total. Here you can see the total excavation of the disc, and only the tube variant of visual field with uh, small areas in temporal part. Primary and angle closure glaucoma, PCG. Etiology: closing of the anterior chamber angle with the peripheral part of the iris root with iris root. Here on the picture you can see the normal variant, open angle, and here it is closed variant. Closing of the anterior chamber angle with goniosine here. And blockage of the anterior chamber angle by a displaced anterior iris lens diaphragm. So, in all variants, we see the closing of the open of the angle of the anterior chamber. There are some predisposing risk factors of this variant of glaucoma. It is anatomical features of the eye, small sizes of the eyeball, big crystalline lens, anterior location of the iris and ciliary body. Age-related changes of the eye, applanation of the cornea, iris root atrophy, the lens getting more heavy, thin zonal is getting weakened, anterior chamber is getting narrow. Physiological mydriasis while reading, watching TV, and during anxiety and emotional stress. Pharmacological mydriasis with atropine, tropicamide, using of sympathomimetic drugs, for example, adrenaline, and static walk with head tilt. There are different variants of primary angial closure glaucoma, and first of all, we will speak about the pathogenesis of glaucoma with the papillary block. The contact of the posterior surface of the iris with the anterior lens capsule in the pupil area here. Uh, then obstacle of the outflow of the aqueous humor, the posterior chamber into anterior through the pupil. The aqueous humor stay here in the posterior chamber. Increased pressure in the posterior chamber combined to the anterior chamber, and as a result, the thin peripheral part of the iris here curves anteriorly, bombing, and touches the structures of the anterior chamber angel here. And the angel is closed, leading to the significant increase of IOP. Uh, and with the circle block of trabecular outflow, if there is circle block of all pupil, this situation it goes to the an acute attack of glaucoma, very severe condition, and the visual acuity can be lost very quickly for some hours. About acute attack and subacute attack of angel closure glaucoma. After exposing of provocative factor, patients notes fog rainbow circle around the light source, but there is no severe pain. It lasts 20-30 minutes, so patients do not consult a doctor. IOP is elevated, it can be 30-35 millimeters hidratum. It can occur at any stage of glaucoma. An acute attack of angel closure glaucoma is rapid and uncontrolled rise of IOP up to 50-80 millimeters hidratum. It's very high pressure. Not decreasing spontaneously, it can continue for 3 days. And as a result, the patient lose his vision and become blindness. What symptoms we have in an acute attack? Eye pain radiating to the half of the head, nausea, vomiting, heartbeat, abdominal cramps, decreasing of visual acuity, blurred vision, rainbow circles around the light source. A pain occurs due to compression of nerves of iris root and ciliary body. Corneal edema, first mainly endothelial edema. And closing of angel of the front camera about the entire circumference. Also, we can see the bombing of iris in glaucoma with papillary block. We spoke about it. The anterior chamber is shallow or slit-like. The pupil is dilated, oval. The reaction to light is reduced or absent. Stagnant injection of the anterior segment also. Symptom of cobra. Symptom of cobra we see here. The vessels of the conjunctiva is very wide and have specific view. Optic disc is usually edematous with full blooded veins and small hemorrhages in the disc tissue. Decrease of visual acuity to 10-9%. Anterior chamber is very shallow, slit-like, or even absent. Angle of anterior chamber is oval and fixed. reduced light reaction. Uh, Except the primary glaucoma, there is a secondary glaucoma. It can be the result of inflammatory glaucoma, inflammatory processes. Inflammatory glaucoma is the result of inflammation in keratitis, recurrent episcleritis, scleritis, and uveitis. Phacogenic glaucoma are three types of it: phacotopic, phacomorphous, and phacolytic. The third variant of secondary glaucoma is vascular glaucoma, includes two clinical and pathogenic forms: neovascular and vein hypertensive glaucoma. And the fourth one is traumatic glaucoma, decrease in trabecular outflow due to post-traumatic changes in the trabecular as a result of mechanical, chemical, or radiation damage to the eye. Okay, congenital glaucoma. Congenital glaucoma, it is glaucoma of children up to 3 years old, which start in these ages. Uh, about etiology, it's disorder of outflow of aqueous humor from the anterior chamber of the eye to the scleral sinus due to congenital anomalies of the structure of the anterior chamber angel. Remains of an embryonic mesodermal tissue that didn't resolve at birth. Disturbance of cleavage and differentiation of the structures of the iridocorneal angel and combination of these congenital anomalies. Beginning in the first 2 up to 3 years of life, and uh, there are such complaints as photophobia, lacrimation, blepharospasm. Um, the child rubs his eyes. What about intraocular pressure? Uh, we need to say that intraocular pressure in these ages measure under the general anesthesia, and tonometrical variant of pressure is more than 23 millimeters. Heterargum and can reach 40 millimeters and above. The corneal diameter comes more than 12 millimeters. Here you can see the buccal cornea. Uh, about gonioscopy, its angel is open. Structures are hardly differentiated. Dyskinesis of the angel, anterior attachment of the iris, corneal edema, of course. The optic nerve, a steady increase in the size of optic cup to the optic nerve. Treatment of congenital glaucoma is only surgical, but intraocular pressure must be lowered by medical treatment before starting surgery. Goniotomy is the removing of goniotomy and trabeculotomy is two variants of surgery. Goniotomy is the removing of mesodermal tissue in anterior chamber angel. Here you see it. Trabeculotomy is excision of trabecular meshwork to better outflow of aqueous humor. We will see it later. About medical treatment of glaucoma at all, there are different eye drops, and there are different variant of different groups of eye drops to treat glaucoma. First, it's drugs that improve the outflow of intraocular fluid. It's, for example, prostaglandins F2 alpha, it's latanoprost, miotics, and selective sympathomimetics, brimonidine, for example. It's a group of first choosing of when we choose the treatment of glaucoma, we firstly choose this variant of drugs. Uh, Eye drops that inhibit the production of intraocular fluid. There are three variants, it's beta blockers, selective sympathomimetics, and carbonic anhydrase inhibitors. And the third variant of medicals of drugs, it's combination with timolol, brimonidine, brinzolamide with timolol, and other. So you need to remember three main groups. First of all, the group that improves the outflow of intraocular fluid. The second that inhibit the production of intraocular fluid, and combination of drugs. About the treatment of acute attack of angle closure glaucoma. First of all, we should immediately begin the administration of miotics. According to the special scheme, one drop every 15 minutes for the first 2 hours, then one drop every 30 minutes next 2 hours, and one time per hour for another 2 hours. In addition to the installation of miotics, we can use timolol. Also, orally, we can use acetazolamide. Orally or intravenous osmotic diuretics we can use. Use specific lytic mixture if we have no results of previous treatment. Also, except the drugs treatment, we can use distraction treatment, hot food baths, for example, salt laxatives, mustard plasters. If the attack couldn't stop during the first day, surgical treatment must be administered to this patient. To make the truth diagnosis of glaucoma, we need to use several methods. It's tonometry, tonography, provocative tests, corneoscopy, perimetry, ophthalmoscopy, of course, visometry, and optical coherence tomography of the optic disc and the retina. What about tonometry? Tonometry is a procedure that performs to determine the IOP. There are three main methods of tonometry. Palpatory method, you can see it here on the upper picture. Applanation contact variance is Maklakov method and Goldman method. And there is non-contact procedure of tonometry. When we check the palpation tonometry, we can with using letter T tonometer and +1 or -1 or +2, 3, -2, 3 when we see the different pressure in the eye when we palpate the different pressure in the eye. About Maklakov's tonometry, the patient is lying face up on the examination couch. Doctor installates topical anesthetics because we need to use the contact plummet. The patient should look on the fixation point and locate the plummet on the center of the cornea. The researcher pushes the eyelids apart with one hand and he sets the tonometer on the eye with help of the supporting hand. The cornea becomes flat due to plummet weight, and on the bottom of the plummet, the print of the cornea is reflected. This print should be unsealed on the alcohol sulfur paper, and IOP is determined by using special charts. Here you can see the process of Maklakov's tonometry. It is the result on the plummet. And here you see the special chart where we can compare our result with special numbers in the ruler. And we have three levels of IOPS: normal one from 16 to 26 millimeters hydrogram, moderately increased from 27 to 32, and high increased from 33 millimeters hydrogram and above. Non-contact ocular tonometry. There are specific devices after tonometer with using of air and palpebral tonometry. You see it here. What we also use to check intraocular pressure. It is 20 hours IOP measuring. There are two variants of it. It's measuring twice a day within 8 hours. Different provocative tests. It's water drinking test, dark test, position test, test with medratics. These four tests are positive if IOP increases on 5 millimeters hydrogram and above. And one more test is pilocarpine test. Test is positive if IOP decrease on 5 millimeters and above. The next diagnostic method is elastotonometry. We use specific plumpets uh, of 5, 7, 10, and 15 grams in sequence. It is named Filatov elastotonometer. Results are writes down on coordinates. You can see the results on the picture. The normal difference between the first measure and the last one is from 7 to 12 millimeters hydrogram. Tonography. Tonography is a method of determination of the production and outflow of the aqueous humor, not only tension, but also the characteristics of outflow and production of aqueous humor. There are four points of results. Its tension, pin 0, is true IOP from 9 to 22 millimeters hydrogram. Also outflow facilities, let us see, and aeration of outflow rate is letter F in tonography. And the last is Baker's coefficient. It must be no more than 100. Here you see on the picture the procedure of tonography. The next method is gonioscopy. Gonioscopy is a method of contact ophthalmological examination with gonio lenses together with a slit lamp to view the iridocorneal angle. It helps us to differentiate open angle and angle closure glaucoma. Gonioscopic grading system when the angle is of anterior chamber is closed, and this grade 4 is open angle of anterior chamber. And here we see all structures of angel. Here we see only the cornea and the root of iris. There is another variant of classification of the angel of anterior chamber, and it's narrowing. In open-angle glaucoma, there are several gonioscopic signs which we can detect during the gonioscopy. You can see them on the picture. Here it's Schwalbe line, trabecular, iris pigment granular. On the previous side here, you can see them too. Schlemm's canal and trabecular too, you can see them. Tests of Perimeter tests to check the visual field. Firstly, we will speak about confrontation test. We don't need any devices here and measures peripheral vision compared to examiner. The patient and examiner cover one eye with a card, the palm, stand about 50 centimeters away and maintain eye contact. Advanced finger starting from periphery and ask the patient to say when the finger is first visible. Inability to see when the doctor sees the finger is suspected peripheral field pathology. Visual field testing, perimeter test. Perimetry is done to obtain accurate examination of the peripheral extent of the visual field. Perimetry may be done as manual kinetic using a Foster's or Goldman type of ball perimeter, or static by automated Humphrey visual field analyzer or the octopus. The extent of normal visual field with a 3 mm white color object is superiorly 55, grade inferiorly 70, nasally 60, and temporally 90 grade. Here you see the patient and examiner with Foster's variant of perimeter. Visual field changes, we can see them on the scheme. It's variant of studying of narrowing, then the central part only, and tube variant of concentrical narrowing and tube variant of visual field. What patient with glaucoma sees? With moderate glaucoma, they see in the central part details, and in severe glaucoma, only the tube vision. Uh, when we speak about the treatment, we need to say not only about medical treatment, but also about surgery treatment. And firstly, about laser treatment of glaucoma. First, it is laser iridectomy. We spoke about the secondary glaucoma with a block of pupil, and laser iridectomy is using here, first of all, laser trabeculoplasty, when the laser through the gonio lenses goes to the angle of the anterior chamber and makes the wounds in the trabecular. About surgical treatment of glaucoma, there are several variants of surgery. First of all, is fistulizing penetrating surgery. Then non-fistulizing, non-penetrating operations. Operations that normalize the circulation of aqueous humor. Operations that reduce the production of aqueous humor. And operations with the use of drainage system. Penetrating and fistulizing surgery and also the drainage systems are using widely. Here you can see the drainage system used in glaucoma surgery. One of the most popular variant is Ahmed drainage.